Hello and welcome to this webinar for Poverty and Childhood Cancer Outcomes, which is hosted by the Society of Pediatric Psychology, HEMONC, SIG. And we're so excited to be here today. My name is Pooja Patel, and I'm a pediatric psychologist from Dell Medical School here at the University of Texas in Austin. And I am so lucky to be here with Dr. Bona, who's going to present on health disparities. We are here to honor this month. September is Sickle Cell Disease Awareness Month and Childhood Cancer Awareness Month. And as that, we've been disseminating webinars to help increase awareness and promote more about these very important areas. As I said, I'm joined here today with Dr. Bona, who is the Assistant Professor in Pediatrics at Harvard Medical School. She's an oncologist at Boston Children's and Dana-Farber Cancer Institute. Her area of research focuses on health disparities, and we're so lucky to have her here today to tell us more about this very important topic. So without further ado, I'm going to pass it over to Dr. Bona.
Thank you so much for that very kind introduction. And let me share my screen. All right. Thank you for the kind introduction. My name is Kira. I'm a pediatric oncologist, and I'm very excited to speak today about some of the research my group has done looking at poverty and childhood cancer outcomes. So my plan for the next 30 minutes or so is to start first with just some definitions and background, and then really to do a quick review of research by my group focused first on targetable measures of poverty and childhood cancer, and then on some data that we have on the associations between poverty and relapse and survival in the pediatric cancer population, and wrap up then with some current intervention development and testing that we're doing. And then to close with some thoughts on future directions, both for research in this area as well as what we need to be doing from a clinical perspective as we provide care to children with cancer. So the overarching research agenda of my group is to identify the impact of poverty on pediatric cancer outcomes. And one of those reasons is that I think in pediatric cancer, we have a real opportunity to leverage the systematic care delivery that we provide and the high event rates that we unfortunately see to think about mechanisms and interventions that can reduce outcome disparities. And I say this as compared to general pediatrics, where there is, of course, decades of beautiful disparities research. But the opportunities to iteratively test interventions and kind of move the needle in terms of improving outcomes, I think, are more limited than in the subspecialty population. And so today, as I mentioned before, I'm going to talk through some data on the associations between poverty and outcomes, a work that is ongoing thinking about mechanisms that might be linking poverty with outcomes, and then wrap up really with this focus on what can we possibly do about it, which is the most important question from a clinical setting. All right, so the context, poverty in pediatrics. As I am sure most of you are aware, child poverty is unfortunately highly prevalent in the United States. 1 in 5 children in the United States lives in poverty. That's if you use the federal government definition of less than 100% federal poverty level, which in 2020 is just about $25,000 a year for a family of 4. If you use the more generous definition of less than 200% federal poverty level, which is considered low income, then 2 in 5 children in the United States lives in poverty. Why does this matter? This matters because in general pediatrics, there's robust evidence demonstrating that poverty is associated with inferior outcomes, including both developmental outcomes, access to care, rates of hospitalization, infectious disease, injury, and mortality. All that being said, poverty is not currently considered a risk factor for poor outcome in childhood cancer, and poverty measures are not routinely collected on pediatric cancer trials. I have a particular poverty measure of interest called household material hardship, which I will just define for you here. And just to be clear moving forward, I will refer to this as HMH because it rolls off the tongue a little faster than household material hardship. HMH is a concrete measure of poverty that overlaps and intersects with income poverty, but is not exactly the same construct. And the important difference is that HMH is a measure of poverty, which in general pediatrics, it's been demonstrated that this can be systematically screened for from the clinical setting, and more importantly, that it can be intervened on with improvements in outcomes. HMH is defined as basic resource needs, those things that all of us need to live on a day-to-day basis, including food, housing, transportation, and utility insecurities. HMH is common and it matters to families. And so let me give you some very brief background on this before I move into more of the outcomes research. In pediatric oncology, the very first research investigation I did as a fellow was to do a survey study of families at a single center, Dana-Farber Cancer Institute, where I was in my fellowship, to simply ask families whether or not they had unmet basic resource needs at home, including food, housing, and utility and security. And the punchline of that survey study was that at the time of diagnosis, so within 30 days of receiving their child's cancer diagnosis, 1 in 5 of our families at Dana-Farber told us that they were living with either food, housing, or utility and security. And when we resurveyed those same families 6 months into chemotherapy, nearly 1 in 3 families, 30%, told us that they were living in a household with at least one unmet basic resource need. And this despite ongoing standard of care psychosocial supports and resource supports provided by a large academic medical center. Those numbers are striking, but I think the other piece that was most striking to me early on as a fellow doing this research was that this matters to families. And I think that's not particularly surprising, but at the same time, sometimes it's good to see their words. And so as part of that survey study, we also interviewed parents, asking them about their experiences. And I put up here 2 representative quotes that you can read. But really the take home from these is that not only is HMH highly prevalent in our patients, but it is something that impacts their day-to-day experience while caring for a child with cancer. As Mia's mom said, I'm not sure how I'll be able to buy groceries and pay for car insurance or rent most months. And the mental toll and worry it brings is exhausting and keeps me awake most nights. Shauna, who's the mom of Madison, a 2-year-old little girl with leukemia, said, going out to the car and finding that it wouldn't start, and it's really scary when you have an appointment an hour and a half away that's life-saving to your child. So with that as the foundational work leading into what I'm going to talk about today, the first set of questions that I was interested in investigating was the very fundamental thing. Is poverty in fact associated with inferior outcomes in pediatric oncology in the same way that it is in general pediatrics, for example? To address this question, we have now done a number of retrospective cohort studies leveraging published data from completed clinical trials in pediatric cancer. And I'm going to present data from a handful of those today. So the first was an investigation of neighborhood level poverty and outcomes for children with acute lymphoblastic leukemia treated on Dana-Farber ALL consortium protocols. The objective of this retrospective analysis was very straightforward. It was to identify the relationship between neighborhood level poverty and ALL disease outcomes for children who were treated on a multi-center clinical trial. The data set included data from consecutive phase 3 multi-center trials that were run between 2000 and 2010. These were DFCI protocols 00001 and 05001. And our cohort for analysis included 575 children who were ages 1 to 18 years, had an upfront diagnosis of ALL, and had an available zip code for analysis. And that last eligibility requirement is because the Dana-Farber ALL Consortium, much like COG and other trial consortiums across the United States, has not historically collected parent-reported socioeconomic measures. And so what we had available instead was a child's zip code at time of enrollment on trial that we were able to link to US Census data to identify a zip code as either being a high poverty zip code or a low poverty zip code, which is a census definition, where a high poverty zip code is defined as greater than 20% of families in that zip code living in poverty, less than 100% federal poverty level. And on this slide, I'm just putting the punchline of that investigation. On the left, you see a panel. These are classic Kaplan-Meier curves demonstrating overall survival for children treated on these trials. In black are children who lived in zip codes that were not poor. In red are children who lived in zip codes that were poor. And you can see that those curves diverge and that there was a difference in overall survival for children based on their neighborhood poverty exposure. When we did multivariable analyses, adjusting for NCI risk criteria and other tumor variables, this becomes slightly insignificant with a p-value of 0.07. I will say we were underpowered to detect this association, but nonetheless, in the multivariable analysis, this did not fall out as being independently prognostic. On the other hand, on the right-hand panel here, this is a curve of the cumulative incidence of relapse for children who were treated on trial. Again, in black are children from low poverty zip codes. In red are children from high poverty zip codes. And you can see that those curves come together. There is absolutely no difference in this cohort of patients in the rates of relapse between poor and non-poor zip codes. What is different is how quickly they get there. And so you note that the red curve gets there a whole lot faster. And our striking finding in this analysis was that among children who experienced relapse of their ALL, children who lived in high poverty zip codes were significantly more likely to experience early relapse, which is defined as less than 36 months in remission, and which is the most important prognostic factor in terms of our ability to successfully put their leukemia back into remission. In fact, among children who relapsed, 92% of kids who lived in a high poverty zip code experienced an early relapse, as compared to only 48% of children who lived in low poverty zip codes. We subsequently shifted gears to look retrospectively at data in neuroblastoma, which is the most common extracranial solid tumor in childhood. And here again, you'll note a similarity with the objective, which was pretty straightforward, to identify the relationship between poverty and high-risk neuroblastoma outcomes for children who were treated on trials between 2005 and 2014. The data set for this analysis was a children's oncology group data set. And so here we used merged clinical trial data from two trials run in the early 2000s, ANBL-0032 and ANBL-0931, which were targeted immunotherapy trials run for kids with high-risk neuroblastoma. Our primary outcome of interest was 2-year event-free survival and overall survival from trial enrollment. And the poverty exposures here, again, you'll note some similarities to the first study. Here we had access to a child's insurance status, which we dichotomized as being Medicaid or CHIP versus private insurance. Based on the fact that Medicaid-only insurance can be a proxy for household income, given that the vast majority of children in the United States who receive Medicaid insurance do so on the basis of low household income. So we used insurance status as a proxy for household level poverty exposure. At the neighborhood level, again, we had zip code, which we were able to link to census data. And then we did a post hoc analysis where we went back and we created combined exposures of both household level poverty and neighborhood level poverty to look at whether that synergistically impacted outcome. And again, here I'll show you the punchline curves. So on the left are Kaplan-Meier curves of 2-year event-free survival for children with high-risk neuroblastoma treated on 0032 and 0931, dichotomized by household level poverty status. In red are children who are not exposed to household level poverty. In blue are children who are exposed to household level poverty. And you'll note that there is a dramatic difference in those curves with significantly different event-free survival between the groups. On the right is a Kaplan-Meier curve of 2-year overall survival. And again, those curves diverge significantly. In multivariable modeling for these trial data, household level poverty remains independently associated with both event-free survival and overall survival with hazard ratios at 2 or above 2. In other words, in this cohort, once we added household level poverty into the models, including tumor variables and treatment variables, this is in fact one of the most highly significant exposures to predict outcome for kids treated on these trials. So, those are two specific studies that we have done. I put up here some slides from a handful of other studies because after those data, we then went and looked across the continuum of care. On the bottom there, I show you bar curves for children with advanced cancer and symptom burden in retrospective analyses of children receiving palliative care interventions on multi-center clinical trials for advanced cancer. Poor children are significantly more likely to have higher symptom burden and lower health-related quality of life despite receipt of palliative care. On the right, this is a curve from Christy Hardy at Children's National, who has led neurocognitive outcome studies for children with ALL, and found that children who had Medicaid-only insurance were significantly more likely to have neurocognitive deficits after therapy than children with private insurance. What I took away from these retrospective data were that despite standardized care on multi-center clinical trials, poor children with cancer in the United States are more likely to relapse, and poor children with cancer in the United States are more likely to die. And the implication for me is that poverty therefore represents a target for intervention, which then begs the question of, okay, what are the mechanisms that we think might be driving this? And I put up here 3 mechanisms that we hypothesize might underlie these outcome disparities. The first is the idea that perhaps poverty is associated with decreased adherence. Smita Bhatia and the COG group have demonstrated that non-adherence to oral chemotherapy in the setting of upfront treatment for acute lymphoblastic leukemia is associated with risk of relapse. And in her data set, lower household income was associated with a higher risk of non-adherence. And so certainly that could be a driver, for example, of some of the outcome disparities we saw in the leukemia cohort. A second possible mechanism that we've considered is, might poverty be associated with dose modifications and treatment delays? What do I mean by that? Data from general pediatrics show us that low-income children in the United States are more likely to be in poor health. They are more likely to have comorbid illness, for example, asthma or obesity or type 2 diabetes. And might it be possible that this underlying health status coming into a diagnosis of cancer is associated with increased chemotherapy toxicity and therefore provider dose reductions in their chemotherapy or delays in their treatment? Conversely, is it possible that kids who are treated on trials and therefore clearly accessing care at institutions quite able to provide standardized care delivery still have delays in access to care when we think about those more mundane day-to-day activities? For example, if it's 2 in the morning and your child has a fever and we expect you to be in the emergency department in the course of the next hour, but you don't have a car. If we go back to that quote from Madison's mom talking about going out to start the car and finding that it wouldn't start, might that result in delays in showing up to care such that your children are potentially sicker when they present and end up having delays in chemotherapy as a result of that? And then finally, the third hypothesis that we are actively investigating is the idea that perhaps poverty exposure might be associated with therapeutic resistance to chemotherapy or immunotherapy based on physiological responses to poverty-associated stress. And I'll talk more about that a little bit as we go on. So with all that as the background, I was going to quickly summarize some research that we have ongoing right now to try and address some of those hypotheses, and then talk a little bit about where I see us going in the future. So I'm going to highlight 3 different projects. The first bucket of investigation that we're doing at the moment is to do trial-embedded poverty data collection in the context of multi-center clinical trials. And the goal of this is really to overcome a number of the limitations in the retrospective data that I showed you, where we were relying on proxies for poverty exposure. So insurance as a proxy for household level poverty exposure, or zip code linked to census data as a proxy for neighborhood level poverty exposure. The second bucket of research that we're working on right now is the development of poverty-targeted interventions and testing those in the clinical setting. And then the third is translational collaborations, utilizing poverty-annotated biospecimens to investigate the concept of treatment resistance. So to the first area of investigation, we are currently conducting a trial-embedded prospective inception cohort study in the Dana-Farber ALL Consortium. The parent trial is Dana-Farber Cancer Institute Protocol 16001, and this is an upfront ALL trial designed to treat children between the ages of 1 and 18 with a new diagnosis of acute lymphoblastic leukemia. Within that trial, we have an opt-in embedded household material hardship survey that parents can choose to participate in. And if they are participating in this ancillary study, they complete a survey within the first 30 days of enrollment, so during induction chemotherapy. And then we ask that they recomplete those surveys every 6 months during the 2 years of chemotherapy. The objectives of this study are to identify the relationship between baseline poverty exposure as reported by parents and first, early relapse and overall survival. This is the primary aim that we're powered on. Second, adherence to oral chemotherapy. And then third, healthcare utilization, looking at lengths of stay in the hospital, ICU admissions, and emergency department visits. We are aiming to accrue 380 children across 7 sites in the Dana-Farber ALL Consortium. And as of last month, we have enrolled 211 children in this opt-in study with an 86% consent rate and no missing HMH data. And I will simply highlight that this is the first trial-embedded investigation of poverty and outcome conducted in a US consortium trial. And one concern going into this was, would parents be willing to participate in an opt-in survey study that explicitly is asking them questions about their poverty status, their food insecurity, their income, for example. And I would say our experience so far in DFCI 1601 has been a resounding yes, that parents are willing to participate in this research. An 86% opt-in consent rate is pretty fantastic for this type of work. But more importantly, once they consent to participate and then they're actually completing surveys for us, the fact that we do not have any missing HMH data, I think really speaks to the fact that this experience for parents is something that is meaningful and that they are interested in telling us about. And so I do think there's value simply in recognizing that. I put up here, I have 2 slides of preliminary data from this trial. We're still accruing data. I don't have data on outcomes yet, but I can tell you 2 things. So the first is, unfortunately, HMH exposure is extremely common in pediatric ALL. At the beginning of this talk, I showed you data from a single center that surveyed families within 30 days of diagnosis. Here, these are data from 7 centers who are enrolling children on an upfront ALL protocol. And the punchline is that at the time of diagnosis, so enrollment on an ALL clinical trial, 34% of parents are reporting that their household is experiencing food, housing, or utility insecurity. I did break that out on the side between US and Canada because the Dana-Farber ALL Consortium includes sites in both countries. And I think the important thing to note here, number 1, is that Canada, well, there's many things that could be said about that. Canada has a strikingly low rate of HMH for patients enrolled in this trial, but probably more pertinent to my work is how high that actually makes the US rate. So in fact, over 40% of children at US centers enrolling in this study are living in a home with at least one unmet basic resource need. Well, I don't have any trial endpoints yet because the trial is still accruing. We have done some preliminary analyses to look at some of our proxy outcome measures, so ones that we're able to gather earlier. And one of those that we're very interested in is the concept of parent distress, and whether poverty exposure and the experience of living in poverty while a child's receiving cancer therapy might impact parents from a distress perspective. And probably not surprising to any of you, the answer to that preliminarily, and these are unadjusted numbers, is that absolutely yes, parents who report that they are living in poverty have significantly higher distress scores. So here we're using the Kessler-6, which is a global screening score, certainly not specific to identifying anxiety or depression or any other pathology. On the left are bar graphs of parents' Kessler-6 scores at time of diagnosis, stratified by the presence or absence of household material hardship. And you can see that parents living in poverty, 24% of them have a Kessler-6 score over 13, and that's as compared to 13% of parents who are not living in poverty. On the right is that same bar graph 6 months into chemotherapy on trial. And I think the really striking thing about this is that we see in the HMH absent families, so families not living in poverty, that a far smaller proportion of parents are screening positive for distress on the Kessler-6 as compared to those families who are living in poverty, 6% versus 22%. And so again, while these are preliminary data, I do think they really open up some opportunities for us to be thinking about other outcomes associated with poverty exposure that we can be targeting with interventions moving forward. The second approach that we're doing is to also look at this in solid tumors. And so we have a very similar trial-embedded survey study in the current open COG high-risk neuroblastoma trial, AMBL 1532. And here, the aim of the study is to identify the relationship between baseline parent-reported HMH and child event-free survival and overall survival, as well as to look at receipt of MIBG. That is a secondary aim that's being conducted by Lena Weinstone at UCSF. We are targeting an accrual of just over 500 children, and this COG trial is open across 120 US and Canadian sites. And we're actively enrolling, and we have enrolled, I have here the number of 50 as of March. Our July numbers, we now have over 100 children enrolled. We are seeing a similar frequency of HMH in this cohort, with 40% of children enrolled on this high-risk neuroblastoma trial living in a home that endorses at least one basic resource need. So shifting gears a little bit, that's ongoing work collecting data prospectively in the clinical trial setting, which I think is going to be invaluable to answering questions about mechanisms that are driving poverty-associated outcome disparities and helping us to identify families who may need an added layer of support from us in terms of care delivery, which then gets to the question of what might we be able to do about this. So the second area that we're actively conducting research right now is in intervention development. And we have developed a novel poverty-targeted intervention that is called PDCare, which stands for the Pediatric Cancer Resource Equity Intervention. This is a direct resource provision intervention that provides groceries and transportation to low-income families during the months that they're receiving chemotherapy. And this intervention builds on foundational work that was done in general pediatrics, much of it at Boston University and investigators in Gen Peds there. which has demonstrated that screening for basic resource needs, so for HMH in the Gen-Ped setting, is feasible. And that if you are able to successfully connect families with existing resources, so a classic example of that would be that a family screens positive for food insecurity, and you're able to connect them with food stamps, for example, or with a food bank, that is able to reduce HMH, and more importantly, that it's able to improve outcomes. Now in Gen-Peds, the outcomes that they're interested in looking at are things like on-time well-child visits or vaccination rates. In pediatric cancer, given that the outcomes I'm concerned about are things like relapse and survival, one worry that I had was that a resource connection intervention, like done in general pediatrics, might be necessary but not sufficient to actually impact outcome disparities. And so we're taking the approach of building on that and actually providing the resources directly to families when they screen positive. So the design for this is a 2-center randomized controlled pilot feasibility study. Our primary outcome is feasibility, which we have defined as a greater than 75% consent rate and greater than 80% follow-up data. And we are enrolling families with pretty basic eligibility criteria. Their child needs to have a new diagnosis of cancer in the last 2 months. They have to be planned to receive at least 4 cycles of chemotherapy, and they have to screen positive for at least one domain of a basic resource need, so food, housing, utility, or transportation and security. We are targeting an accrual of 40 families, and this study is open at 2 centers, Dana-Farber Cancer Institute in Boston and University of Alabama, Birmingham, in Birmingham, Alabama, where Dr. Julie Wolfson is our site PI. We are a little over halfway through our enrollment right now. And I will say that while we clearly have not completed enrollment thus far, we have a 100% consent rate to participate, and we have no missing data. And so the takeaway that I have thus far from this study is that families, again, are willing to engage on this subject. More importantly, that they are willing to participate in randomized supportive care interventions, which is essential for us to know moving forward if we're going to try this in the clinical trial setting. And then finally, the third area that we're actively conducting research is in the translational science space. And so I mentioned back at the hypothesis slide that in addition to thinking about adherence and access to care and parent distress, one hypothesis that I have about how poverty might be impacting disease outcomes for children with cancer is that perhaps poverty-associated stress might induce epigenetic or immune responses that confer treatment resistance. And if that's true, it would be very important for us to understand as we think about the treatments that we deliver to children. And so building on work, again, from general pediatrics, really what led us to think about this was those neuroblastoma curves that I showed you before. You know, certainly outcome disparities in ALL have been demonstrated, but there are these very nice data from the Children's Oncology group and Dr. Bhatia demonstrating that non-adherence might be a primary driver of that. High-risk neuroblastoma is a pretty different disease, and these curves that I showed you before, the event-free survival differences between poverty-exposed and unexposed children receiving targeted immunotherapy, these reflect a cohort of children who were receiving inpatient therapy delivered at select groups of Children's Oncology group academic medical centers. And to see such a large difference in relapse, for me, really begs the question of, is there some biological difference that we're missing here? And so to investigate those questions, I'm currently collaborating with a number of colleagues who run wet labs to think about, in the ALL setting, is poverty perhaps associated with epigenetic downregulation of glucocorticoid receptors? Also in the ALL setting, is poverty associated with excess risk of neurocognitive late effects? And this is a collaboration that I'm doing with Dr. Christy Hardy and Peter Cole. And then in the neuroblastoma setting, might poverty be associated with epigenetic downregulation of GD2? So that work is ongoing. What are the next steps and where do we go from here? I would say, in my mind, there's really 3 major next steps. The first is awareness. This is not really a research aim, but I do think it's a clinical aim, and clinical interventions and clinical healthcare delivery changes are the entire purpose of the work that we're doing. And so I would say number 1 is awareness. We need to be asking about this. Number 2 is data. We need more data on social determinants of health and how they're associated with outcome. And in my mind, that requires an expanded trial-embedded portfolio. And number 3 is interventions. And when I say this, I showed you work we're doing piloting one intervention, but I think the community as a whole needs a broad portfolio of poverty-targeted interventions and other interventions targeting social determinants of health that track along with poverty, whether that be literacy, non-English language, single-parent households, families with low social support. And these interventions need to be being tested across the continuum of care and with a broad range of outcomes as their interest. So with regard to ask, what do I mean by that? Data that we have produced and data from other groups shows that 1 in 3 families with a child on active cancer treatment is unable to afford at least one basic need. And that is something in my mind that we need to change. And I think one of the first ways that we change that is by thinking about systematic clinical data collection. So not for research, but thinking about it in the care setting, because I personally, as a pediatric oncologist, think it's important for me to know if a kid I'm giving chemotherapy to is living in a household where there's not enough food. That feels to me as though it's something that we as a clinical care team should care about and that potentially we can think about intervening on. I've put up here just an example of one household level screen that we're using at my center. There are many other examples that are out there, but there are a number of standardized measures that are very brief that take families about 30 seconds to complete, where you can gather basic data on whether they are concerned about basic resource needs at home. And then the number 2 and 3, data. I have a vision that moving forward, every trial in pediatric oncology should have embedded social determinant of health data collection. And I think that every trial that we run needs to be thinking about social determinants of health as exposures that have the potential to impact outcomes. The goal here would be that we would have more robust data with which to annotate disease outcomes, which are typically the primary outcomes of the trials we run, to annotate biospecimens and let us be able to do translational work in this space. And perhaps, I was going to say more importantly or equally importantly, to facilitate supportive care and psychosocial care by identifying families who may be at greater risk of parental distress, greater risk at symptom burden, or inferior health-related quality of life in the child receiving care. Similarly, I have a vision that moving forward over the next 10 years, what our field needs to do is think about interventions across the care continuum. And so by this, I mean the idea of, in the same way that we have in pediatric oncology, a diverse portfolio of therapeutic drug trials, I think we similarly need to be exercising a diverse portfolio of healthcare delivery interventions. And I think we have a real opportunity to leverage the very strong clinical trial infrastructure that we already have in place in pediatric oncology to embed interventions like this right alongside our drug trials. I would argue that we need to do this in the upfront disease setting, but also in the setting of relapsed and refractory disease, in the setting of survivorship, and certainly in the setting of palliative care. And then finally, the third place that I personally need to be thinking more broadly about, but I think we as a field need to be doing as well, is that of outcomes. My group has focused a lot on looking at disease outcomes, relapse and survival, but I think we need to be thinking far beyond that, including parent anxiety and cognitive bandwidth, child healthcare utilization, child quality of life, adherence, as well as biomarkers. So in summary, poverty is independently associated with outcomes in childhood cancer. My personal goal is to improve childhood cancer outcomes, including relapse, survival, and patient-reported outcomes by systematically integrating poverty into our model of care and discovery. I think it's a real opportunity in pediatric cancer. 1 in 5 children has this, quote, novel cross-disease risk factor. And so I would argue that a place we need to go is systematic poverty data collection in every pediatric cancer population, targeted intervention testing across diseases in the continuum of care, and translational collaborations. And my vision would be that pediatric oncology can serve perhaps as a demonstration model in which we can identify mechanisms and then test interventions that eventually could be extrapolated across other populations where we know very similar disparities exist, including adult oncology as well as pediatric subspecialty medicine. And so with that, I will simply acknowledge the many people who have supported my work and myself, including my mentor, Joanne Wolf, as well as a number of collaborators and the funders who have supported this research. Thank you so much for your time and attention. I very much appreciate it.
Thank you so much, Dr. Bono, for that very compelling presentation and all of your meaningful work that you've done in this area. In preparation for this webinar, we asked our SIG to share some questions that they might have in this area. And so I'd like to ask you a couple of those questions.
Great.
So obviously, maximizing the cure will always be the primary focus in pediatric oncology. But do you think that it would ever be worth it to focus on developing treatments that intentionally aim to minimize the financial or socioeconomic impact that this has on families?
I think that's a fantastic question, and my answer is yes, definitely. I also think it's important to note, I'm not sure that the two are actually disconnected from one another. I think if we are able to successfully integrate data collection and interventions focused on financial toxicity, focused on social determinants of health, I think we actually have an opportunity to improve disease outcomes for kids with cancer. And so I think that it doesn't have to be an either or. I think we can be doing these things alongside one another. My interest and approach is in doing this in the therapeutic trial setting. And I think that you can embed ancillary studies there, but certainly doing studies that are running parallel to trials or which enroll children who are receiving standard of care, I think is a very important next step.
Yeah, that makes a lot of sense. You've presented a lot of compelling reasons why that's so important. In your presentation, you shared, that socioeconomic factors play a significant role in adherence and can impact relapse rates. Why do we not view those factors in the same way that we do, for example, the Philadelphia chromosome positive ALL? It seems like we should treat patients differently based on their socioeconomic risks that could interfere with treatment efficacy and increase relapse rates. What is your view on this?
I could not agree more. That is like a question after my own heart here. I guess I would say to that, in answer to why don't we do that, I think that answer has a long history in pediatric cancer, where we historically have not considered social determinants of health to be risk factors for outcome. And some of that I don't think is insane. I think that we as a field have thought that we rely so heavily on standardized care delivery, so heavily on clinical trial care delivery at large academic medical centers, that we believed that we were capable of overcoming outcome disparities that have been well described in other populations. And we have thought that we were different. And I personally think that is the explanation for why over the last 40 years we have failed to collect any of these data as part of our trials. I don't think it's because we did it with evil intent. I think we didn't realize that it mattered. I would argue that data now from my group and many, many others show that that is simply not true. And so I think moving forward, exactly what the person asking this question was saying, the idea of using this in the same way that we use genomic risk stratification is where we should be moving as a field. And that this can be used whether you're still enrolled on exactly the same stratum of your clinical trial, but perhaps you're receiving an enhanced supportive care delivery from your psychosocial team, from your resource specialist team, from whomever that is at your care center, could make a really, really striking difference in terms of the outcomes our families and children experience.
Yeah. I have one last question for you. And you presented, and you kind of alluded to this, is that there are, different screening measures or different tools that we can use to kind of assess with families what is happening, what the risk factors are, kind of where their insecurities are. What would you say are the one or two most important things that you would want to relay to our pediatric psychologists out there of what they should be kind of assessing for or making sure their clinics are addressing?
Yeah, I think that's a great question. So I have a bias, which is that I think all of our clinical teams should be systematically screening for social determinants of health. And I say that not as standing alone, but rather that that's in line with the American Academy of Pediatrics 2007 policy recommendation, that these exposures are so important to outcome in pediatrics that we should all be screening. I guess with regard to what should we be screening for, there's unfortunately no consensus on this yet in the field. There's not a single validated measure that exists. But I guess what I would say, a lot of that depends on the resources available at your site. And clearly those who have, for example, a number of social workers or a number of psychosocial providers have greater bandwidth potentially to be doing screening than those who have fewer resources like that. I think the bare minimum, I think the things that we need to know to be providing good care, if you're thinking about poverty and socioeconomic status, probably two things. Family income is important to identify eligibility for existing governmental resources. So when I say that, for example, SNAP or food stamp eligibility, is typically based on household income. And so if you don't know a family's income, it's very difficult to then connect them with existing resources that cost nothing for your institution, but are already out there in the community. Similarly, if I had to pick a single concrete resource need, food insecurity is widely prevalent in pediatrics. There is a 2-item validated food insecurity screening scale, which literally takes 15 seconds to administer, is validated in pediatric populations, including subspecialty populations, and identifies a concrete resource need which can be addressed and ameliorated, whether that's linking families with food stamps, connecting them to a food bank, or using in-house resources to help address that issue. And so those would be the 2 socioeconomic measures. Across other social determinants of health, I would argue that probably the 2 other most basic would be understanding a family's social supports at home, and whether there are additional resources that need to be in place to help them with that. And then thinking about basics like transportation and their ability to successfully access the care that we are asking them to adhere to.
Thank you. That's very helpful. Well, thank you so much, Dr. Bona, for your time and sharing this wonderful presentation with us. And if you don't mind, I have one more slide I'd like to share with our viewers. So if you could stop share, let's see.
Yes.
And I'm going to just ask, thank you so much. So with that, I will leave everyone to say thanks for joining us, and follow us on Twitter, where you will continue to get these updates from our SIG, and we'd love to hear what your thoughts on the webinar as well. Thank you so much, Dr. Bona. It was wonderful spending time with you.
Thank you so much.